So good morning, everyone. This is Robert Hejzak from Czech AIDS Help Society. I am a chairman of Czech Patient Organization and Czech NGO, and I'd like now today share with you our experience from the European Testing Week in 2020 and the impact that the COVID pandemic had on our operation and how we try to maintain our activities during these times. Let me start by giving you a bit of background information about what's the situation of HIV in Czechia. Currently, we register as of end of March 2020, 3,600 HIV positive people living with HIV, out of which about 680 people are diagnosed with AIDS. The HIV prevalence in the country is similar to surrounding countries in the region. We are not the lowest prevalence country anymore. We are somewhere at the same level as Austria, Poland, or Germany. So somewhere between two to five people per 100,000 population. This has changed recently. For a long time we've had a very low figures. We've been one of the lowest prevalence countries in Europe, but now the figures are slowly increasing. Similar to many countries again in the region, the main transmission routes for HIV in Czechia are by sex of men having sex with men, MSM. That's close to 70%, followed by heterosexual sexual transmission. Very low number of intravenous drug users and very low number of vertical transmission. Treatment cascade, Czech Republic has not reached yet the 90-90-90 goals. We are somewhere around 80% today regarding the diagnosis, so there is still quite a large testing gap when it comes to diagnosing people living with HIV. People on treatment, what you see here, 71%, that's figures coming back from 2018. I believe today the figure would be higher. Today more people are on treatment, and I think we probably would have reached already the 90%. Good results on achieving undetectable viral load. Over 90% of people already reached that goal and became undetectable. The key population in general, as I said, is MSM, and in this respect, we are one of the probably 5 to 10 countries in Europe with the highest proportion of MSM among HIV population. We recently see some decrease of this figure, but that's not so much that we would have eliminated the infection among MSM, but it's also to the fact that we have increasing number of heterosexual migrants who are coming with HIV to the country. Incidentally, MSM is also the key target population for our NGO, and most of our prevention services are done for MSM. Now, coming to COVID and how COVID influenced our operation, these are some figures about where we stand today as a country. Czech Republic has registered about 8,700 cases, 300 deaths. And as you can see, most of the peak of the pandemics was coming somewhere in late March, beginning of April. The first COVID case was registered on March the 4th, and on March the 12th, the country was already on full lockdown. The government decided to suspend all public services. Schools were closed, shops were closed. Also, in many cases, the healthcare services were closed and the healthcare was suspended for later times. So this obviously had some impact on our operation as well. Very initially, the first week of the lockdown, we closed our testing facilities, and not just for the purpose of limit access to testing, but also since our facilities include also some shelter housing for people living with HIV, and in case we would have some registered COVID case in the building, we would need to close down also the shelter housing. So initially this discussion was, what do we do about testing? Can we afford actually to have testing open for our clients, since we also have some full-time clients living in our facility. At the end, we decided to maintain the testing. We obviously included some changes to our internal operations. What you can see here is some basic hygiene provisions we started. So every person coming to this testing facility today needs to first fill out a questionnaire where we ask about the general condition, whether there are any signs of COVID infection. Every time, every person is measured his temperature, and then it needs to wear mask the whole time. There is disinfection of hands before entering the testing room, and our staff is equipped with mask and mask shields. We also changed the way we organize the services. It's not anymore a walk-in service where anyone can enter and get tested. We now operate on appointment system only. So you need to have first appointment so that people don't meet actually in the waiting room. There is only also always only one or two people in the waiting room. Some of the other services or activities we needed to launch very early on during the pandemics was to look at whether the health system and the pharma company will be able to continue in providing antiretroviral treatment for our existing clients. So one of the first things we did, we also called all pharma companies to make sure there is enough supplies available in the Czech Republic, especially since at that time there were news spreading up in media that some of the HIV treatment can be used for COVID treatment as well. So we were naturally worried that there might be a shortages of HIV treatment. So this didn't happen. The pharma company cooperated quite well, and all HIV centered kept their provisions for ART during the whole pandemic so far. However, we also had to deal with a number of foreigners who get stuck in the country due to travel restrictions, people with living HIV who had all of a sudden had no access to treatments. For those, we organized some emergency access to treatment, and so far I think we helped over 25 people getting their treatment and maintain their access to treatment. We also decided to interrupt our mobile testing. Our NGO is running not just a network of checkpoints, but we also have two mobile testing units which usually run around the country and do testing close to gay venues or some festivals or outdoor activities. So we decided for the initial phase to completely interrupt this mobile testing, and we will be launching this again only in the end of May and beginning of June. I already talked about the change from the walk-in voluntary counseling and testing and organizing it only by appointment. We also changed the way we deliver results. In the past, each client was asked to come physically back to the testing facilities to get the test results, which was something that we've tried to overhaul several times with the government. It was only during the COVID-19 pandemic that the government or the Ministry of Health agreed that in order to reduce the physical contact and to maintain social distancing, you will be allowed to provide test results by SMS or by other means than just personal contact. But we also decided to look at alternative ways of providing testing, because obviously with this interruptions of mobile testing and a new system of organizing checkpoint testing, there was a considerable drop of people attending our testing facilities. So we were looking at what would be the alternative way for testing, and we decided to introduce self-testing back into our operation. In this graph, I think one gets very clear picture about what was the immediate impact of COVID. As you can see, on average, the blue line figures for 2019. On average, we would test every month around 450 to 500 people, about 120 people every week. And these figures were the same at the beginning of March for this year, 2020. But then in the middle of March, when the lockdown was introduced, we saw immediate drop of number of tests undertaken in our checkpoints, to the point that during the third week of March, we were close to zero. We were only one or two clients coming to get tested. So then, with the introduction of some of the anti-COVID provisions in our operation, we slowly started getting some traffic back, and by the end of March, beginning of April, we were again testing some 50 people on average during each week. However, as you can see, the figures still have not picked up, and we are still somewhere about maybe even less than half of what we were doing in 2019. So at this point, we thought that the self-testing would be a viable alternative to physical checkpoint testing, and we decided to go back to self-testing. Now we were in a way in a privileged position because over the last 2 years we designed a pilot self-testing project which helped us to define the whole procedure to set up some internal processes that would allow us now to very quickly relaunch the self-testing and provide the self-testing kits for free to our users. The original pilot project, which we launched in 2018, uh, was designed to attract MSM in high risk and or people who have limited access to HIV treatment. So the initial idea was to look at people who live in some remote regions who don't have easy access to physical checkpoints or the medical healthcare services where they can get tested. In the pilot project, we distributed over 1,000 tests. It was fingerprint prick test testing, and we use our web-based platform to both identify users who would be eligible candidates for the self-testing, but also to use it for logistics and seeking some feedback from the users. Obviously, with self-testing, there is a need to have a good reference system in place so that clients who have reactive tests can talk to someone, to talk some counselors or get reference to treatment. So thanks to our 24/7 hotline, which was in service for many years, we could provide this service to self-test users and help them either with test administration or with some follow-up questions in case the tests came inconclusive or reactive. Um, Obviously, because it's a pilot project, so we were looking for some user feedback, not only about the user friendliness, but also obviously about the results of the test, and also some additional demographic questions to understand who are the people who are most likely to use these self-tests. So we built in a feedback system, and we used some incentives to get results back. We provided free credit to some of the largest Czech gay dating sites if the user completed the questionnaire. These are the HIV self-tests that we use in the pilot phase, but also this year during the COVID pandemics. It's the, as I said, it's the prick tests. All manuals, all information, user support is in Czech. We selected this particular company which was able to do this local language customization for us so that all information would be readily available. The self-testing project was originally promoted via the gay dating sites. We did not use so much the international gay dating sites like Grindr or Hornet or Planet Romeo. We originally opted for one of the largest Czech gay dating sites, which has over 100,000 registered users, so still a large audience. And in these dating site, we provided basic information about testing, and we did the initial selection. So on the left side, you see a print screen from the dating site. This is our advert. If you're interested in the self-testing, if you click on the link, you would end up on our web page, which is the right print screen on the screen. And there you will get immediate access to our web-based platform for registration. So each client would be asked to fill in some basic question. Obviously, our testing in checkpoints is completely anonymous and free of charge. In case of self-testing, you do need some contact information. So the question of anonymity was discussed internally. We decided to ask clients for some contact details, even though we made it clear that we don't really need to have the proper names, proper address. We just need some address where we can deliver the tests. And we also made sure that all information regarding the client is disconnected from this mailing database. So both databases were kept separately, and the contact details regarding the address were deleted after the self-tests were sent out. So what you see on the second, third, and fourth print screen on this screen, it's the inside of our web-based platform where clients are assigned a login name, and they decide on their own PIN number or PIN access code to access the information about their particular test and test results. Then we ask some basic questions about demographics, year of birth, location of the country where the client is accessing the self-test. And we also include some questions regarding sexual behavior to understand the risk involved and the reasons why the clients are looking for HIV test. So at the end of this questionnaire, our staff will receive an anonymous profile of the self-test candidate, and the application will help us to understand the sex involved, the risk involved. Now, each client then will receive the anonymously labeled package, which is a self-test kit, but we will also provide some additional information based on the risk involved. So, for example, we will also provide some additional information on PrEP if the person is a good candidate for PrEP. We will provide some links to our services for chemsex user if the client indicated in the questionnaire, for example, that chemsex is part of his sexual behavior, or we would provide advice on maybe vaccination for hepatitis A and B. So next slide shows you some of the insights from our database. So this is internal part, which is not visible to client. This is some logistics info on how the tests are being distributed. So what you see on the left side, it's a list of code. So each code represents one client. At this point, it's completely anonymous. Our staff cannot link it back to the mailing address or to the name of the client given on the mailing address. So now everything's done under codes. And it helps us to understand, when the test was sent out, when the test was received by the recipient, and whether we received any feedback back from the client. Here, I'd like to present a bit of feedback results when we ask the clients the feedback about using the self-test. The overall response rate was quite high. I think about 48 to maybe even 50% of all users came back to us with the questionnaire that we asked to fill out after the self-test was done. It confirmed to us that the users are those typically who don't get tested regularly in this in the first phase feedback. Close to 50% of users admitted that they've never had any HIV test done before. It also showed that one of the biggest barrier for them to get testing is the face-to-face contact. People are afraid to get tested in person. They prefer this anonymous way of getting tests delivered to them as a self-test. What the feedback also showed, though, is that clients are not only interested in self-testing if they live in small places in some remote area, but also clients living in larger cities would be interested in self-testing as an option to other testing venues. Some of the questions we also asked regarding the user friendliness. In general, there was very positive reception of the self-testing. And what you can see on the right side, when we also ask questions about pricing, if these tests were commercially available, how much would be the clients willing to spend on these tests? And the general answer was that if the test is somewhere in the range of 12 to 15 euros, this would be acceptable price for pretty much everyone who replied back. So as you can see, over these 2 years, we distributed over 1,000 tests, 1,053 to be precise. We had 2 positive results or reactive results out of 500 response which we received back during the feedback phase. So that's 2 out of 500. Now, during the COVID-19 pandemic, our initial thought was, since we already have this all HIV self-testing infrastructure in place, we already know how to do it, we already had these tests tested, why don't we just extend our self-testing to new clients or to people who would not be willing or are afraid to come to get tested in our checkpoints due to the general situation around COVID. So we launched again this self-testing campaign. This time we advertised not only on the Czech gay gay dating site, but also we used Grindr and we provided access to basically anyone. So this time we are not particularly looking for people who are in high risk or people who have no access to HIV testing. Basically, any MSM who would be interested in undertaking this test would be eligible to receive the test. Now, the HIV self-test funding does not come from the government. It comes from public donors. In the past, the government was not willing to support self-testing. There was this idea that self-testing should not be even allowed in the country, that we should be looking more for medical settings testing, or if necessary, then community testing, but certainly not self-testing. I think that this has changed now during the COVID-19 pandemic. I think the government has realized that self-testing is a way to actually maintain the basic HIV prevention services rather than just disconnect completely from prevention. So what you see here is the comparison again of number of tests that we delivered so far. On the first graph, you see only the tests we did in our checkpoints. So you see there's been a massive drop in our physical checkpoint testing, and we are still not back even to 50% of our previous testing. On the second graph, though, you see that we've been able to actually deliver the same number of tests if we include the self-test. So during the second or third week of April, we reached the same number of tests through our checkpoint testing and self-testing as we have last year in checkpoints. So that shows that the self-testing can compensate for some of the loss of number of clients in checkpoint testing, and can be a good supplementary measure for continuing the HIV testing and HIV prevention. So some of the lessons learned from this exercise, we realized that in our situation, probably in other countries where there is no official guidelines on self-testing and where the government may not be willing to publicly support self-testing, the CE certification of the test is a sort of door opening mechanism. If the test is CE certified, we don't need to ask any other domestic certification. It's ready for the market, and it allows us to distribute the test without any additional certification. There is a question of cost. Who will pay for the self-test? Obviously, if the government is not willing to support self-testing, then it needs to be done either by donor funding or by the clients themselves. Now, we are not in a position yet to sell the tests, even though this is something we would like to develop in the future. But currently, some of the tests are available in pharmacies, and we still can maintain for the rest of the year at least provision of free tests which are sent by mail free of charge to our clients. One of the lessons learned from the pilot phase was that self-testing needs heavy advertising and PR support, because in a situation in a country where clients are not used to self-testing, there is a little awareness about self-test. You need to actually promote the service. It's not just enough to have the test available, but you need to actually go out and promote and explain why self-testing is safe and makes sense, and it's a reliable way of testing. So we had a very strong correlation between number of orders coming from our clients during the months where we ran some PR campaigns or advertising campaigns in social media, and during these months there was a higher interest in acquiring the self-test than in other months. And obviously, self-testing requires also a very strong customer support or link to care, because these clients are not coming physically to our facilities, so there is no face-to-face contact with our counselors. So we had to think about how to provide this customer support, and how do we link these clients to healthcare if needed, if the tests turn reactive and need to be confirmed, or the clients need to be referred to HIV center. We also saw, in a way, COVID-19 as an opportunity, not just a threat. It is certainly an incentive to expand the HIV testing options. HIV testing today is not only about testing in medical clinical settings. It's also about community setting testing. It's about rapid testing in the field. It's about mobile testing. It's about self testing. So all of these options now should be incorporated in our view in the HIV prevention scheme. So strategies so that the clients a wide variety of ways to access the prevention services and testing. Um, we also saw that COVID-19 was the sort of breaking point in our discussion with the government about how we can deliver results, or how we can more um, include some of the basic e-health principles into our operation. So, for many years, as I said, for many years we were not allowed to do any test deliveries other than in face-to-face settings. But now we are able to provide the test result by SMS, which obviously reduces the time for the test delivery, but also reduces the volume of work on our side. We don't need to have our staff tied up to additional post-counseling meetings with our clients. We can do it over SMS. Another possible opportunity for the future is to see if the pandemics, if the COVID virus stays with us in the future, is sort of integrate testing. In some discussions we had with public health officers, there was already a question of how do we whether we could maybe integrate the COVID testing into our operation. Certainly, the use of mobile testing units is something that is worth exploring, because these testing mobile units are already equipped for testing, and it doesn't really matter which kind of test you use in these facilities. But there's also something larger than just testing or HIV prevention, and that's something that we've been discussing with other patient organizations, and is to also to see whether maybe this pandemic, this crisis situation, um, could be a launching pad for further EU integration in the area of health. As we all know, health is currently under the principle of subsidiarity in the national realms. It's not really something that the EU is very strong about, but the communicable diseases are clearly something which is not limited to national boundaries. It's an international threat which needs to be held, which needs to be dealt with on international arena by strong coordination. So maybe this could be a good time to start discussion whether EU integration should continue also in the area of health and health services. And I think this is it from us as a um, exercise of sharing what we are doing currently in terms of testing. And I hope this gives some ideas of how to support testing activities and HIV prevention in these times. Thank you.